Hello, everybody. Thank you very much for joining us today. My name is Gabrielle Richardson, and on behalf of MEGIN, I'd like to give you a warm welcome to this MEGIN Masterclass with our guest speaker, Dr. Julia Stephen. Just before we start, and whilst people are still joining, we have a few housekeeping rules to go over. Please use the Q&A button on your screen to send in your questions at any time during the masterclass. There will be time for Dr. Julia Stephen to answer any questions you may have at the end of this session. Any questions unanswered, we will try and respond in writing after the session. I'd like to take this opportunity to remind you that this webinar is being recorded with the permission of our speaker and will be available to watch on demand on the MEGIN website afterwards. And finally, just a reminder to please adhere to the MEGIN Code of Conduct for webinars and engage respectfully online. So without further ado, it gives me great pleasure to hand over to Dr. Julia Stephen, who will officially kick off the webinar. Thank you very much.
I don't know how to change my slides. All right, sorry, there's a slight delay in being able to change my slides, but I can do that now. So I wanted to talk to you today about the work that we've been doing in understanding how pre and postnatal exposures influence brain development using MEG. So there are a couple of important questions that I think we need to consider when we're talking about what the role of neuroimaging is in healthcare, just very broadly. So how can it contribute? I think one of the questions that we need to consider is how can we deepen our understanding of how the brain works to facilitate future applications with neuroimaging techniques? And then how can neuroimaging contribute to clinical care to improve outcomes? So one of the options along these lines is to look for early identification, for example, of neurodevelopmental disorders. And many of these things are relevant to neurodegenerative disorders and other disorders as well. But what I'm going to talk to you about today are things that are relevant to neurodevelopmental disorders. So one of the topics that I've focused on recently is looking at the effects of prenatal alcohol exposure on brain function. So this is a quote from the Institute of Medicine in 1996, so it was quite some time ago, but we've actually known for quite some time that alcohol is really quite serious in terms of the neurobehavioral effects on the fetus and the child, and really causes the most severe effects relative to other substances of abuse. So what people are most familiar with is fetal alcohol syndrome, which is what I'm showing on the slide here. So individuals with fetal alcohol syndrome have these structural changes in their face that you can identify whether you know that there's prenatal alcohol exposure or not. We also know that there can be changes in the brain, and this is an extreme example. This isn't how it is in most cases, but what we have here are two different brains, a healthy brain from a baby at 6 weeks of age, and then a baby who had been affected by FAS at 6 weeks of age. And you can see that there's dramatic changes in brain volume. So with fetal alcohol syndrome and with these dramatic changes in brain volume, it indicates or implicates that we actually have other ways to identify that these kids have been exposed to alcohol. So the question is what is the role of neuroimaging? Why would we look at this with MEG, for example? And there's a real reason that we need to look at this for this particular disorder. So the challenge with fetal alcohol spectrum disorders is that the prevalence is high. In the US, the current estimates, and this was based on a case ascertainment study, so they actually evaluated these children, and this was based off of a study of almost 10,000 children. They established that 2 to 5% of the kids in first grade have some form of FASD. So it means that they have sufficient either cognitive or behavioral deficits to meet criteria for the diagnosis of FASD, and that they had evidence of alcohol exposure during pregnancy. So the FAS, which I showed you in the previous slide, really only accounts for 0.1%. So the worldwide prevalence of FAS is 0.1%. There's been multiple studies across the years that have looked at this, and the prevalence of FAS, which is just those kids who have this structural change in their face, remains at 0.1% regardless of what has been done in terms of trying to reduce prevalence of alcohol consumption. So what that means is that most of the kids who are impacted by prenatal alcohol exposure don't actually have these structural changes to their face, and because of that, then there are no biological markers for these individuals who do not have FAS, and it's the broad majority of kids who don't have these markers. The other challenge is that both ADHD, ODD, opposition defiant disorder, as well as conduct disorder, are all comorbid with FASD, and so it can also be difficult to try and figure out whether a child has ADHD versus whether they were exposed to alcohol. And the reason that that is important is because the treatment is actually slightly different. So the kids who actually have a background of prenatal alcohol exposure tend to not respond as well to stimulant medication, which works tremendously well for kids with ADHD. So what this indicates is that you need a different treatment path for kids who have FASD. So you have overlap in behavior with other disorders, and you have a different need for treatment depending on what the cause is. So the reason that we care about this is that the life outcomes are poor for kids with FASD without intervention. So they struggle with social relationships, maintaining social relationships, not really instigating them. So it is different than autism spectrum disorders in that regard. There tends to be increased drug and alcohol use and also increased incarceration rates. So we've done a number of different studies in kids with FASD. One of the topics that I've been interested in for a long time is multisensory integration. And what we're trying to look at with this is trying to understand how the brain is able to put information back together after the sensory modalities have sort of separated the world apart into the different sensory domains. So it's a really complicated problem that really still isn't very well understood. So we know that our ears detect sounds, and our sense of touch detects obviously tactile information. Our eyes detect visual information, and all that information gets separated. And then we put that back together to make this multisensory construct of the world. And what we don't know is how the brain is able to put that together so well. And it really requires very precise timing to understand, you know, what sound goes with what sense of touch, you know, what just touched you, or what sound goes with what visual stimulus you just saw. It's very complicated sensory soup, if you want to say, if you want to put it that way, and really making sense of it is not entirely straightforward. So we know that the information comes into the different sensory areas, and then there are association areas that help to put that information together. And looking at auditory and tactile in particular, these areas surrounded in yellow dotted lines are the areas that are really implicated in being able to integrate that information if you're talking about auditory and somatosensory function. So with this first study that I'm going to talk about, we were looking at multisensory integration in kids with FASD, looking both at auditory and somatosensory. And the reason that we were looking at multisensory integration is because there's been quite a history of publication in the field of FASD that is looking at just connectivity in the brain. And so using MRI instead of MEG to look at white matter tracts and try and determine if there are differences in white matter tracts in kids with FASD. And there's quite a literature indicating that they do have connectivity problems, which is actually sort of a common problem across different disorders, but is also present in kids with FASD. So our general hypothesis was that because of these connectivity deficits in kids with FASD, that multisensory integration would be impacted and impacted in a negative sense, making it more difficult for individuals to integrate information across the sensory modalities. So this is just a picture of this experimental design. So we presented auditory stimuli to left and right ears separately, and then we had these little air pressure, air puff devices that were attached to the finger. And so this is just a tactile stimulus to the left and right index finger. And this design is interesting because you look at both unisensory responses, so left ear, left finger, right ear, right finger, but you can also present them simultaneously, so left sound and left finger simultaneously. So this is the congruent multisensory, and then you can look at incongruent, so meaning that you have like right sound with left finger, for example. And this is something that your brain shouldn't really integrate naturally because it's coming from a different side of the body. So you wouldn't envision that this would be something that your brain would want to put together. So this in particular, one of the previous findings was really that corpus callosum was very impacted. And so looking at differences across hemisphere is particularly of interest in kids with FASD. So we did source analysis as we do with MEG, found the primary sensory areas quite easily, and have a number of results from this study because we have both unisensory auditory, unisensory somatosensory, as well as the two multisensory conditions. So you can look at the auditory M100 latency, and you can see that in general, the latency is much faster in both multisensory conditions. So this is consistent with the multisensory literature, but there were no differences by group with these latencies. So multisensory information sort of speeds our ability to respond to auditory stimuli. This is the same for the M200 latency, so the second peak of the auditory response. Again, there were no group differences in this response. So with the somatosensory, we do have a group by condition interaction, which was significant. And what we see in this condition is that the latency for the unisensory response was delayed in the kids with FASD. And this is consistent with just the general idea that information processing is slow in individuals who have been exposed to alcohol prenatally. But if you then look at the multisensory conditions, contrary to our hypothesis, the kids with FASD, actually the latency sped up. So they're actually faster or at least equivalent to the healthy controls as compared to the unisensory condition. So this is contrary to what we thought. We thought that these connectivity deficits would have impacted the latency of the multisensory response, so you would still have that delay, but instead the multisensory information actually seems to help individuals with FASD. And then we see a similar but more complicated interaction between group, condition, and hemisphere if you look at amplitude. And again, if you, then there's, depending on the hemisphere, the individuals with FASD have either reduced amplitude or increased amplitude. And once you get to the multisensory conditions, then these differences went away. Although in this case, it also is a trend for a decreased amplitude. So in general, across this particular study, what we found is that it seems that really multisensory stimuli seem to help individuals with FASD rather than having additional delays. So this same study, we actually looked at neural oscillations as well to try and determine if these neural oscillations are altered. So as a part of multisensory integration, we know that you have to sort of bind things together, and one thing that has been implicated for feature binding is gamma oscillations. So we looked at gamma oscillations with the same paradigm, and this is just a different analysis, but we did find group differences in the gamma oscillations as well in different conditions, and these are all multisensory conditions that I'm showing here. And we also found that there were some associations with behavior in those gamma oscillations as well. So there are a number of different things that we need to consider with this, but one thing that we'd still like to go back to is trying to understand sensory deficits, because even though multisensory is very interesting, it's important to get information into the brain in effective ways in order for us to do any additional processing. So another study that we had performed, and this was a little bit earlier, but we were looking in preschool age kids, but this was just a very simple auditory design. Again, we did source analysis and looked at the timing of those source time courses. And similar to what we had found with the multisensory study, we have this delay in our kids with FASD relative to healthy controls. And that was actually a delay for both the M100 and the M200 peak. What I'm showing on the right is the individual subject data. So this is important if we're trying to look for, if I go back to the initial goal of trying to use neuroimaging in this population to try and identify early neurodevelopmental disorders. What this indicates is that there's quite a bit of overlap, even though at a group level there's a delay in the kids with FASD. If you look at individual subjects, you can see that there are some kids with FASD that have pretty fast latencies for the M100, and then some healthy controls that have relatively slow latencies. And so what this really indicates is that, auditory alone, just presenting a simple tone to individuals, even though you see group differences, is not going to be sufficient for a biomarker per se for identifying kids with prenatal alcohol exposure. So I've talked about auditory and somatosensory so far. We're also interested in the visual system. And one of the findings that has been reported in the field of FASD is that kids with FASD actually have slower saccades. So if you look at the eye gaze network, in the previous publications, they were just looking at behavioral outcomes. So they used an eye tracker to watch the eyes and how quickly do you move your eye from a central stimulus to a target, and then if you are supposed to do an anti-saccade, then how quickly do you look away from the target? And they found that there were differences in how quickly an individual with an FASD can look towards or away from the target. So we decided to use the same sort of thing. So we have an MEG compatible eye tracker available here. And so we used our eye tracker in combination with MEG to look at the visual response in a simple pro-saccade task. So this is just looking at a target from a central stimulus. So if you just look at the visual response, so again, we did source analysis to identify the primary visual cortex, and then looked at the visual response latencies to that visual cortex response. And again, similar to our auditory responses, we also found that there was a delay in the response in kids with FASD. So this is presented slightly differently. Now we have the latency here on the y-axis, and we have two different stimuli conditions: the central stimulus, which is just when you're first fixating, and then the peripheral stimulus, which is the target that you're supposed to saccade to. So if you look at the visual response to either of those, the central stimulus is delayed and significantly delayed for kids with FASD, but it's actually more delayed with the peripheral visual stimulus as opposed to a central visual stimulus. So that difference is significant, and this is actually consistent with a lot of different developmental disorders where it looks like the visual, the dorsal stream of the visual system seems to be more sensitive to some type of insult than the central visual system, the ventral stream. And so again, this is consistent with our previous auditory results showing that there's a sort of delay in the sensory processing in kids with FASD, and this is now adolescents with FASD. So again, we looked at gamma oscillations. This is in the same data set as what I just reported in terms of the latencies. And these are the different regions that we found significant differences in gamma oscillations between our healthy controls and our kids with FASD. This is just an example of one of those findings from the cluster 2. For example, and in this case, the kids with FASD had reduced gamma oscillations relative to the healthy controls. But what was interesting about this is that if you now correlate the gamma power with the target M100 latency, which I just reported on, then there was actually a positive correlation between those two things. And what we determined from that is it seems that, and this is a different cluster that what I'm showing here, in this case, then the kids with FASD actually had increased gamma oscillations. And so what our conclusion from this result is that it seems that the gamma oscillations seem to help the kids with FASD catch up in terms of their saccadic reaction time. So this is how quickly they respond to the peripheral stimulus. So unlike the previous green publications saying that there was a delay in the saccadic reaction time, with this particular study in adolescents with FASD, there was no group difference in the final outcome, the saccadic reaction time, even though there was this delay in the visual processing response. And so the gamma oscillations seem to be one of the possible mechanisms for their ability to catch up from these early sensory delays. And again, we seem to see associations between these neural oscillations and behavior. So we did a few different neuropsych tests with these kids with FASD. So this was an intra and extra dimensional shift task, and we saw both a negative correlation between the gamma oscillations and total errors. So this really indicates that increased gamma oscillations was related to fewer errors. And then for beta oscillations, there was a positive correlation where increased beta oscillations was actually related to an increased latency. So in this case, increased beta oscillations would have been not helpful for outcome in these individuals. So we've continued to work on trying to understand what the differences are in kids with FASD relative to healthy controls. And this is a more recent study published just last year. We're looking just at resting alpha oscillations. So the design of the study was just to have the individual close their eyes, open their eyes, and close their eyes again. Even though we were focusing on gamma previously, we looked at across all the different frequency bands, and where we found a significant difference was in alpha. And this has become a topic of interest for us for a number of reasons. I already had mentioned that kids with FASD have an overlap in ADHD behavior, so attention deficits, and alpha more and more in the literature really seems to be related to attention abilities. So showing that there are differences in alpha power. In this case, it was only in the kids with fetal alcohol syndrome. So this is a subcategory of kids with FASD, and the kids with ARND did not show a significant difference in alpha power relative to typically developing controls. But it is, there are also some correlations with behavior. So this is now the brief, which is a questionnaire for the parents asking about executive function abilities in the children. And there were correlations, especially with the kids with FASD in alpha power. And in this case, decreased alpha power was related to increased executive increased executive function score. And this is actually a norm is 50, and so this is problematic. So we would also like to really, again, going back to the initial question or purpose that I said that we're for using MEG for this population is for early identification. So this is one of our previous studies also, which was really focusing on trying to understand if we can look for early markers of prenatal alcohol exposure. So again, one of the challenges with kids with FASD, similar to many neurodevelopmental disorders, is that it's difficult to identify these kids and diagnose them at a young age. So in studies where you're looking at infants before they have cognitive and behavior, cognition and behavior that you can assess reliably, we really refer to these kids as kids who have prenatal alcohol exposure, but we don't know what their long-term course is, whether they're going to have cognitive and behavioral deficits to actually end up with an FASD diagnosis or not. But we did focus on kids at 6 months of age, and we did a simple mu rhythm task. So one of the challenges with doing work with infants is that they can't explicitly follow instructions, and so you really need to develop tasks that they're willing to do just as a matter of course in everyday life. So one thing that kids like to do at 6 months of age is hold on to things, and this allows you to look at both resting, just normal resting behavior in the infants, and then also looking at grasping. And so one thing that we know changes between rest and grasping a tool or a toy is the mu rhythm, which is also an alpha oscillation, but that originates from the somatosensory cortex. This task involved the infant not sleeping. We actually had them awake. And they were offered this toy off many times. And then we did a lot of post-processing of the data to make sure that the child was happy and engaged and watching the investigator who was providing them with the toy and then squeezing and then resting in between. So we found quite significant differences in the left hemisphere in our individuals with prenatal alcohol exposure. So in this case, we saw differences across the different frequency bands, and we did not see a difference in the right hemisphere. So this is consistent with some really early EEG work that was done in individuals, in kids who had been exposed to alcohol prenatally. But that was never followed up. So this is consistent with the prior literature, but this hemispheric effect had not been reported with the previous EEG studies. And the other thing that we reported with this study is that there was a dose effect. So if you look at the kids with prenatal alcohol exposure, and this was a log of the estimated total number of drinks that the kids had been exposed to, that was directly related to the amplitude. And as you can see, the kids with prenatal alcohol exposure had what was referred to in the EEG literature as hypersynchrony, or increased power relative to controls. So this may still be a biomarker of early prenatal alcohol exposure. So our overall results from the PAE studies are really suggesting that there's slow information processing across many different sensory areas. And contrary to our hypothesis, multisensory processing does not seem to be impaired in individuals with FASD, but instead improves sensory processing deficits that were there. And then we also have consistent results indicating that neural oscillations that are different by group are also related to behavior. So I also want to keep moving on to other factors that impact development in otherwise healthy children. So we have spent a lot of time looking at kids with prenatal alcohol exposure, but we're also looking at neurodevelopment more broadly. One of our big studies that we did recently was the developmental connectogenomics study, or the DevCog study. This was focusing on kids 9 to 14 years of age, and we followed those kids longitudinally for 3 years. And what I'm reporting on in the next few slides are some pieces of that, but it was quite a large study, and it was multi-site. So this was both MRN and University of Nebraska Medical Center in collaboration with Tony Wilson. So some interesting things to think about in terms of trying to understand more broadly what we need to consider when we're looking at neurodevelopment. We did have some, this is just a description of the population that we studied for the DevCog study. We did see some differences in socioeconomic status, which is shown up in the upper left. But we also have quite a number of traumas in these individuals. And this is important because there are a number of different populations of kids who are exposed to traumas throughout their life. But this was a typically developing cohort, and we still had quite a reasonable percentage of individuals who had 3 or more traumas that they were exposed to. And then you can see that between the 2 sites, parental stress was about equivalent, but we also saw a difference in attention between the sites. The reason that I want to bring this up is because if you look at this difference in SES, so socioeconomic status was on average higher in the Nebraska group relative to the New Mexico group. And in general, the inattention, so a higher score is worse. The inattention score was actually higher in individuals in New Mexico relative to individuals in Nebraska on average. And this is actually consistent with the literature suggesting that SES alone seems to have some impact on attention abilities. We also have a recent study just published in 2021, really indicating that alpha power in particular, so if you are looking at different markers in the brain, that alpha power is different in the frontoparietal network in individuals with high attention versus individuals with low attention, the blue dashed line. So across different regions, medial frontal to parietal, you can see that alpha power is consistently lower in individuals with low attention abilities. So again, we think that there are a number of things that we need to consider in trying to understand neurodevelopment broadly and understanding how that relates to attention and ADHD. So this does go back to the attention deficits that we know are present in individuals with FASD. So this is a study that was published from the DevCog sample that was just looking, this was an MRI study, but we did find that there were differences between males and females in the low trauma versus high trauma group. And the reason that I wanted to present that is that we're now looking at differences in both hippocampal volume in combination with genetic history. So if you look at the 5' HTT-LPR allele specifically, so this particular allele has been implicated in different response to stress during childhood. So if you have a particular allele, then you just respond differently to stress or traumas, for example. And we do see a difference. This was the original finding. If you look at it by allele type, this is the short allele, and where you really see a difference in hippocampal volume is just with this particular subgroup. So we think it's important to not only consider male-female variables, but also genetic type as well. So we also know that there's a difference in attention between the individuals with low trauma versus high trauma. So the individuals who are exposed to more traumas have worse attention. So again, this is inattention, so a higher score is worse. And then if you look at the MEG responses, and this SART is sustained attention to response task, so that's an attention task. We see that there are differences in the response in that attention task using MEG depending on allele type. So this gets very complicated very quickly, but this is one of the larger adolescent data sets and largest MEG data set that we're aware of in the adolescent age range that really allows you to start looking at these more complicated factors. So we also know, and this is just a short pilot study that we did in 6-month-old kids, but we were looking at maternal PTSD. So the effects, is there an effect of maternal PTSD on infant brain function? And we did find a correlation between maternal PTSD. So again, this is looking at a different variable that also seems to impact neurodevelopment. And this has been shown behaviorally that it really matters what the maternal's sort of mental health state is for the infant's long-term outcomes. Some of the more compelling results is that kids who are born to mothers who are depressed, for example, have higher rates of depression as they grow up. So this again indicates that we need to account for kind of broader environment when we're looking at neurodevelopment. So I've been focusing mostly on MEG results, but I do think it's important to continue to do multimodal analysis, and we've been doing this through a number of different studies. So we use this approach called joint ICA, which allows you to integrate both MEG and DTI data. It actually allows you to integrate many different types of data. Historically, it's been used for fMRI and structural MRI integration, but we used it specifically for integrating MEG and DTI because I do think that looking at the structural connectivity relative to what we can measure with MEG, that really allows you sensitivity to timing and amplitude, which is also sensitive to connectivity between regions, means that MEG and DTI integration is highly motivated. So this was our initial study that we looked at, and this was focused initially on individuals with schizophrenia, but we've now applied it to kids with FASD. So we looked at just at the sensor level and linked that to different white matter tracks. And then in our FASD study, we found in particular that there was this one component, component 5, that was related to sensory responses and linked it to the cerebellum. So differences in white matter in the cerebellum were directly related to amplitudes in our sensory responses with MEG. And the level of association between the cerebellar white matter and the amplitude in these sensory responses, this loading factor, was correlated to vocabulary score in the healthy controls, but not in the kids with FASD. And this difference was statistically significant. So we think that it's important to look at these associations, and then and we see that there are links to behavior as well. And the final study that I want to talk about is, again, a more recent study that was just published looking at corticothalamic connectivity in kids with FASD. So going back to the alpha oscillations that I've already talked about, we've known for quite some time that alpha oscillations just during rest are primarily driven by the thalamus. And so what this indicates is that you would really expect, if there are one possible explanation for a decrease in amplitude and alpha oscillations, is that perhaps the connectivity between thalamus and cortex is impaired. And so this is looking at just the DTI results. We did see significant differences in these corticothalamic tracts in kids with FASD relative to typically developing controls. And as hypothesized, this is looking at fractional anisotropy measures. They're lower in the kids with FASD relative to typically developing controls, and statistically significantly different. And then we also found a correlation between alpha power and the FA value for these different tracks, for 3 of the tracks. And this was particularly significant in the kids in the typically developing controls, but not really as correlated, not significantly correlated in the kids with FASD. So it does look like there's some sort of breakdown in the association between alpha power and corticothalamic connectivity in the patient population. So the overall conclusions, I think it's important to continue to push for a more complex view of brain function in order to understand what is really going on. And I think that this information is important to feed it back to really clinical usefulness. So hopefully, if we can really understand what the differences are, then maybe we can use neuroimaging to identify biomarkers for different neurodevelopmental disorders. I think it continues to be important to develop stimuli in more realistic scenarios to better understand brain function in everyday life. And in general, I think we need to continue to improve methods for early identification and intervention for neurodevelopmental, neurological, and psychiatric disorders. So there are a number of people who have been involved in this work, and I want to thank all of them, and then a lot of funding as well, and I'll end there.
Thank you, Dr. Julia Stephen, for your time today. We will be making this masterclass available on demand, and thank you everyone for attending. We hope to see you on future masterclass programs.
And also we have a few questions in the chat. So one of the questions is, what early interventions are there for children with an FASD?
So thank you for that question. There are very few interventions specifically for kids with FASD currently. So NIH actually has a call out currently to try to spur development of more interventions for kids with FASD. So right now they get ADHD medication and treatment that is intended for other disorders, but there are a few evidence-based interventions that are focused on very specific deficits. So there's one focused on math training, and then most of the rest are really family intervention type techniques, but there's a large need still.
And our next question is, these studies with moving infants must be challenging in conventional MEG systems, which are very movement sensitive. Would the new OPM MEG technology facilitate studies in moving infants?
Yeah, it's a very relevant question. So I think, you know, from my perspective, when I've been focusing on neurodevelopment for the last 15 years, the OPM technology is absolutely very exciting as a possibility. You know, of course, there's a lot that needs to still be worked out because, you know, I don't want to lose the high spatial resolution that we have with you know, 306 sensors, and most of the OPM systems that are still there, you know, people are working with, you know, 10, 20 kind of sensors, which is useful, but doesn't get you to a whole head coverage, which is still so important and relevant. So I'm really excited about the future. I don't think it's there yet.
Okay, I have another question here. So we have, what are the levels of alcohol intake in mothers that are associated with FASD? Are the changes in infants greater if the mother has mental health issues as well?
Yeah, so the, I mean, the current American Pediatrics really recommends that one should not drink any alcohol during pregnancy because there is a dose effect, and there hasn't been sort of a safe level determined. So one of the unique things about looking at kids with FASD and prenatal alcohol exposure is that there are very relevant animal models because you can expose animals to prenatal alcohol exposure. So it's actually quite, you know, it's similar to the disorder that you're trying to study, unlike many other neurodevelopmental disorders where we don't really know how to model it with an animal model. So we do know that from a lot of those animal models that it appears that you can have effects at the cellular and molecular level, even with as little as one drink a week. So they really really are currently recommending that there's no safe amount. And then if the changes are greater, if the mother has mental health issues, there are a number of different things that really interact with kind of the amount of alcohol exposure, including genetics. So some people are lucky and they metabolize alcohol very quickly, and so there would be less of an effect. But if the mother is in that situation, we don't actually know whether the fetus is in that situation. So this is where it gets very complicated to understand the long-term effects of prenatal alcohol exposure, because you have this very strong genetic component. And then if you have these other prenatal and postnatal factors, that is also problematic, which is, really why I'm interested. We're trying to understand all of the factors that are involved in the effects of prenatal alcohol exposure, because this may or may not be just alcohol. It may also be postnatal factors, like it's referred to here in terms of maternal mental health, or just hostile home environment, things like that. So they're all important factors to consider and to try and understand what things are most important for really optimizing outcomes for kids.
So we have another question. It starts with, thank you for your impressive talk. You found changes in somatosensory M100 amplitude and brain oscillations in the left hemisphere of FASD and PAE. What do you think about the relationship between their symptoms and the brain alterations in the left hemisphere of FASD and PAE?
Yeah, so the hemispheric effects are difficult to understand, because with the infants we saw this very strong left hemisphere effect, but the hemisphere effects kind of evolve with age. And as hopefully you picked up, I have been looking at infants with prenatal alcohol exposure, preschool age kids, 8 to 12-year-olds, as well as adolescents. So we've really been looking across the age range, and that strong left hemisphere effect gets washed out. So it's not as lateralized, even as you go to just the preschool age. So we're not quite sure what to make of that strong left hemisphere effect in the infants, but we know that there are a lot of different factors that seem to maybe sort of resolve, the brain. Some of the interpretations of the results of either animal PAE models or some of the other results is that, the brain is still trying to heal itself from this prenatal insult, essentially. And so it is a complicated story. We don't know long-term which hemisphere effects that we need to worry about, and this is a non-answer to the question mostly, but it's because we haven't seen, I thought that there were actually more right hemisphere effects in our adolescents, and so that kind of is completely different than what we see in the infants. But we also find, if we just look at rest, so we saw that hypersynchrony across the frequency bands in the infants, and we don't see that even in 8 to 12-year-olds. So things seem to have normalized in some sense. So what we're trying to understand, with more studies, larger studies, more participants, so we can more strongly say things, is to really understand how things evolve with neurodevelopment. And I think it's a lot of interplay there.
We have another question here. Are the hemisphere defects basically just down to which is the most dominant hemisphere? Most of the time the left is the most dominant. What happens to people who have the right hemisphere as the most dominant?
Yeah, it's a good question. The dominance tends to happen. So kids generally don't have a dominant hand, for example, until maybe around 5 years of age. So but the hemispheres also develop at different rates. So some of the work by Chris Edgar has really been looking at different development rates of the different hemispheres. So it could have something to do with dominance of the left hemisphere at that particular time window. I think it's an interesting question.
And we have a follow-up to that one. For FASD, are the defects mainly conscious/cognitive defects? Are there some unconscious defects as well?
There's a range of deficits. So there's both cognitive and behavioral effects. So they can have challenges I had already mentioned in terms of like maintaining friends. A lot of those things have to do with executive function deficits. And that's what you see with a lot of the cognitive effects. But attention is also very much affected in individuals with FASD. And then as far as the unconscious, the only thing that I would be able to sort of report on with that is to say, well, do we see differences when you don't see any other effects, is the only way I'd be able to interpret that. You know, with the PAE kids, these kids with prenatal alcohol exposure that were recruited into the study actually had pretty low levels of alcohol exposure, and they still showed these pretty robust differences relative to the typically developing controls. So I think that there are kind of a broad range, and that's really borne out in the preclinical work as well. So there are quite a few different effects.
And we have one final question. How can MEG contribute to the field of FASD?
Yeah, I think there's still a number of different things that that MEG can contribute to the field of FASD. So the average age of identification for kids with FASD is still 9 years of age, which is, in my opinion, very late, and really too late for early intervention. So, you know, really trying to, so I pointed out that like the auditory response, for example, is not a good biomarker on its own. The question is there sort of a combination of measures that you can use to identify kids with prenatal alcohol exposure? So there's the early identification, but we're also trying to use it to understand, you know, if I think it's important for interventions still, and this is a broad comment, not just specific to FASD, but for neurodevelopmental disorders, we really want to understand if we have some sort of intervention, does it normalize brain function, or is the brain function different, but still they're more functional? So what is the intervention doing in terms of their neurodevelopmental course? And I think, you know, really having the sensitivity to look at brain responses really allows us to start answering some of those questions. So are these kids improving in a different path, or are they following kind of more of a neurotypical path?
Well, thank you for answering these questions, and to everyone that was attending today, thank you for joining us for this MEGIN Masterclass. Thanks.
Thank you, everyone.